complexity risk of our procedures. You could see that majority of our procedures here represented in the orange and the red bars are complex or even the most complex ones. So why do we need models? We need models because we are not living in the two-dimensional world of medical imaging, and the heart doesn't live in that. Heart is essentially a 3D organ. It moves around and it swirls and twists itself. So we need 3D models to illustrate that. And also surgeries, they happen in the three-dimensional modality. And that requires a certain amount of imagination from surgeons, cardiologists. Heart models have a long history, starting from almost like 5,000 years. As you can see, this Olmec little statue. And then only in the 20th century that we had function and structure combined together in MRI and in other very modern modalities like 3D echocardiography. Over the centuries, and especially starting from the early 20th century, people, they were studying on heart models. And this is the lady who actually started it, Dr. Maud Abbott. And I myself was educated on cardiac specimens, but these cardiac specimens are general and they are not individualized. So we need more models. Now, on the top of it, majority of our procedures are, we are implanting something like a prosthetic material. I can see the more complex surgery we do, the more likely we have to implant something. And that relates congenital cardiac surgery to reconstructive surgery and additive manufacturing. Additive manufacturing started in the early 80s and started in the research lab and then followed into factories and now homes. And that's quite a big business right now today. When we are talking about 3D printed prototypes, we are basically talking about two types of models. One of them is 3D anatomical models. The second one are patient-specific prostheses, implants, external fixators, splints, surgical instrumentation. This is what I'm not going to talk about right now because we are not as yet there. What I'm talking about is the anatomical models, which we get the imaging data set from imaging sources like CT, angio, MRI, in selected cases, 3D echocardiography. And then we create something like a segmented model on the computer screen, and that segmented model can be printed out into finished 3D prototype, or we can project that data set into the virtual reality. Again, that I'm going to talk about later. Why is it important to have 3D models? Because the tactile or haptic information that we get by having these models in our hands actually can augment the visual information that we get by our eyes. And that's very significantly important. So the assumed benefits of these 3D printed models that they promote a better understanding of complex anatomy. We can test different alternative surgical scenarios and emulate the operation. And also we can improve the communication and cooperation in the team, not only in the clinical team, but also with the parents. And they often bring new anatomical information, and all these benefits, they come before we actually go to the operating room. Of course, these benefits are not universally acknowledged. Preoperative planning was only found beneficial, only half of the studies, and accuracy was even less. And the time saved in the OR is complemented by the fact that we spend considerable time by creating the models and waiting for the printing process. And there are additional costs as well as drawbacks, but I think the improved patient safety that we can achieve with the models, that pays off all of these possible drawbacks. We undertook the study in Sheikh Khalifa Medical City in Abu Dhabi, which is the #1 pediatric cardiac service in the UAE, where we perform around 400 surgeries per annum, mostly on a neonatal early infant population with a higher complexity compared to international average. So we looked for the key study questions, whether these models, they offer an added value for the service, and whether this 3D printing process translates in a better team dynamics and building, let's say, a shared mental model about the patients and about the surgical procedure. I can see that new anatomic information transpired in almost like about 2/3 of the cases, and they promoted a better surgical strategy, almost like 90% of the cases. And there was no morbidity or mortality occurred in this series, thankfully to the models, at least in partly. Yeah. When we print out models, we always print out two models. One of them is called a blood volume model. This is what the name stands for, actually what the blood takes in the cardiac chambers in the great vessels, and the other one that where you have wall characteristics, it's called a hollow model. And then we compare these models to the intraoperative scenario, and you probably see that they are fairly accurate, even in this very complex scenario with dextrocardia and a lot of other diagnostics that are given in the bottom of the slide. Or in this other case where we had actually no way from the CT angio to figure it out why this patient was having very poor ventricular function. And the patient previously had a prosthetic valve implanted. And first, of course, the surgeon wants to know whether that's something related to his or her own activity that results in a poor ventricular function. So we looked into the model to see how the left main coronary artery is related to the prosthetic valve, nicely seen here in blue. You can see it's almost 1 centimeter above. So that was ruled out that this prosthesis has anything to do. But when we looked carefully to the model, we could see the right pulmonary artery actually compressing the origin of the the left main coronary artery. And that actually gave us an operative plan how we can release this area. So the model was quite indispensable in this case to save the patient's life. In this other scenario, the model actually helped us to avoid a disastrous complication. As you see, the left coronary artery giving rise to the left anterior descending artery, and the right coronary artery very abnormally arises from this branch. So when the surgeon actually cuts the pathway open to create something like an unobstructed pathway to this small pulmonary trunk, he could have actually cut through the coronary artery with disastrous consequences. So the model actually saved life in this situation, and this is something that we couldn't really see as clearly on the 2D imaging. In other cases, the models helped us to plan strategically for the surgical procedure, which vessel should come first, how we can create something like a pulmonary circuit in this situation when the pulmonary circulation relies on collateral arteries, and there is no connection between the heart and the pulmonary vessels. When we deal with reoperations, that's basically something like a diminishing return scenario. You bring even higher risks with, let's say, less and less surgical success. So you need to prepare for that surgery very well. In this case, the pulmonary veins, they come into the left atrium with very narrow orifices. And then with the help of the model, we could emulate the surgical procedure. And the beauty of that we could actually find out the different scenarios where to cut, where not to cut. And we could do that on the model. Actually, these models are printed with the physical characteristics of arteries that resemble to heart tissue as well. So we could actually feel what tissues we are going to work in the heart. And then you can see that compared to the preoperative assessment, this is the intraoperative picture, pretty much accurate. And in this case, the patient's life was luckily saved. Now, in another scenario for this little girl who was deemed inoperable, we could print a model, and the model could offer some insight into the anatomy and could actually give us some hint where we could do some surgical procedure without jeopardizing complete heart block, other, again, disastrous consequences. And this patient went for surgery and the life was saved. And the model gave us another very important detail that namely the left coronary artery was coming very, very high, actually in the intended area of the aortotomy. And again, that would be quite fatal to cut into the left coronary artery when we open the aorta. So again, the model gave us very good insights. So all these scenarios carry a great patient benefit, a better understanding of the conditions, more realistic expectations, more comfortable options, and much more clear-cut information for that. And all the other potential benefits like cutting down intraoperative time and cost, anesthesia time, infection rate, radiation, those are other benefits or potential benefits that we can offer. Of course, there are team benefits as well, like improved communication, that everybody is focused and everybody knows his or her role, even before we go to the operating room. That's also very important in team building and create something like a safe environment to do with these sometimes quite risky multiple reoperations. Now, let's talk about the future a little bit. And I've already mentioned that we can transport these images into the virtual reality, like holograms. And those holograms, they can project it back to the operative field. For example, in minimally invasive surgery, we can actually nicely design where the best approach to the heart could be, where the surgeon should make the incision, and where which approach we can actually conduct the surgery from. And that with micro robots can pave the way towards new surgery, when we can actually do the surgery without opening the chest and creating these really very risky scenarios for the patients. So that's one of the, let's say, first half of the circle around the patient. And the other half of the circle could be image-guided design. As I mentioned, we implant a lot of extra material to the patients. And unfortunately, those materials, they cannot grow, and they are not natural or viable materials in most of the cases. And unfortunately, that renders to the patients to reoperations in the future. If we could come up with natural material that can grow and viable, and especially if we could print out those materials, those designed for the individual patient, could be a great public health benefit. And I think all those new technologies like nanotechnology, bioengineering, new materials, and bioprinting would complete the circle around the patient that could be the pathway to neurosurgery. Of course, Dubai is leading the world platform for 3D printing in becoming a global hub for 3D printing, and medicine is one of the bullet points, or the first bullet points in India. And these are my conclusions or the way forward. I think we need to expend more time on education because, not only in the clinical practice, but also education, these are very much beneficial efforts. Of course, we need to exploit the clinical and economic potentials in a quantitative manner. Unfortunately, at the moment, there is no insurance reimbursement for 3D printing. So that's something that we need to sort out. Financial coverage is very important, and regulations and standards are being developed. And definitely, I think that all requires a center of excellence in 3D technologies in healthcare, and especially in pediatric cardiac surgery as well. And with that, I would like to thank your attention and give you this last slide by saying shukran jazilan, or sishie in Chinese. Thank you. Bye-bye.